evening, everyone. Welcome to our webinar today. We truly appreciate your attendance and joining us. I hope I hope it's clear. Can you hear me?
Yes.
All right, good. Our session tonight is titled Introduction to Pivotal Response Treatment, PRT. We're honored to have two distinguished speakers who will share their experts and insights with us. First, we have Dr. Grace. She is a PhD, BCBA. She's a clinical professor and director of the Autism Intervention Program at Stanford Department at Psychiatry and Behavioral Science. We're also pleased to welcome Devon Slab. She is also BCBA Master. She is the director of the ABA Early Intervention Program at Stanford Medicine Children's Health. We're so excited. Please enjoy the webinar and thank you. Let's get started.
Thank you so much. We're so delighted to be here with all of you. And thanks for the invitation to share some introductory comments and information about pivotal response treatment. What we're going to do first is just acknowledge that every person with autism is different, that one of the things that we can do to help autistic children the best is to acknowledge their diverse strengths and interests. I love to quote this colleague of mine, Sally Rogers, who developed the treatment, the Early Start Denver model. And she likes to say, follow the smile, which I believe is a really good clue for us about how to motivate children to learn and how to integrate the most unique aspects of each individual's strengths and interests to help with their treatment. So I hope today that we'll be able to help you figure out how to follow the smile as you are engaging with young children who have autism. So why are we here? We're here because we want to figure out how to help young children succeed. We all have this common goal of trying to help children do the best that they can in the circumstances that they're in. And we have a challenge, a common challenge of trying to motivate children to try. A lot of times, young children who have autism feel discouraged and they might try things that don't work. And we want to help them figure out that their behaviors do have a positive effect on the world and that they can actually learn how to communicate effectively and interact in a way that feels good. So the pivotal response treatment techniques are designed to help children want to try more. And hopefully, as a clinician, you might find these interesting and useful as you interact with young children. There are lots of components of effective treatment, as I know you're all aware. Quite a long time ago, almost 25 years ago, in the United States, the National Research Council published a guide called Educating Children with Autism that outlined some of the most important components of effective treatment. And these are still really important to bear in mind. We know that early intervention is important, so the younger that we can identify young children who are at risk for having delays or difficulties, the faster we can get them started with treatment, the more effective that treatment will be. We know that family participation is really critical. The more we can involve parents and caregivers and siblings and extended family, the better the children will do. We know that treatment in natural environments is really important, whether that means doing treatment in the home or in the community, or making the clinical areas that we deliver treatment in as natural as possible. And then we know that it's important to teach functional skills. It's more important to teach children things that they'll need in their everyday life so that they can have really meaningful outcomes. It's less important that children just follow directions or name things on a flashcard, but if they can do things that that really will help them in their everyday life, at the playground, in their homes, at their school, then that is the most important type of meaningful outcome. So when we do pivotal response treatment, we're asking this question: can we increase the intervention power by selecting what we call pivotal treatment targets? Pivotal means something that's going to have a big effect on other areas of development outside of the areas that we're directly targeting. And I hope we'll convince you today that that is possible. Before we dive into the specifics of pivotal response treatment, I want to share a kind of conceptual model that we use to think about the range of early intervention types of treatments. So many of you are familiar with a range of ABA-based strategies for treatment, applied behavior analysis. And as you know, you can do that in many different ways. You can use ABA in many different ways. So I'm hoping to help you see how pivotal response treatment fits into this framework. Number one, we could ask, who is the leader of the treatment? Number two, we could ask, where does the teaching occur? And number three, we could ask, what is the goal of the treatment? And so when we're talking about the leader of the treatment, on the one hand, we could have a treatment that's highly adult directed, where the grown-up is the one who decides what the child is going to learn. In this picture, you see there's a mom who's showing some flashcards of a turtle to this little boy, and she's decided that turtles are important. And those techniques do work, but we have major benefits if we can actually let the child lead the treatment. This little guy already knows a lot about turtles, and if we're going to be teaching him about something he's already this interested in, we'll have major advantages in terms of the speed of his learning and his generalization of the skills. Secondly, we can consider the setting. So sometimes we teach in more structured settings, in a room with a table and sitting at a chair. It's possible to teach in that manner, and it can be effective. But there are major advantages if we can also teach during daily routines, during bath time, during going to the park, during meal times, during play with siblings, during natural routines at school. And third, there's a lot of variability in what the goal of the treatment is. So we could teach kids discrete skills, matching colors with construction paper like this little boy is doing. And that could be important and effective. But there are major advantages if in treatment we can tap into the important relationship building goals and find a way to teach more than just discrete skills, to teach things that are going to have an effect on the child's ability to build meaningful relationships over time. So the name of this type of treatment, the kind that incorporates, like you see this little boy with the turtle, that incorporates child-directed learning in natural settings, that focuses not just on discrete skills, but also overall relationship building. The name of this type of treatment category is naturalistic developmental behavioral interventions. These are the types of ABA-based treatments that also integrate developmental theory and are taught in natural settings. And pivotal response treatment, as many of you know, is one of these NDBIs. PRT has been recognized for a long time. It was developed in the 1990s, and it's been named in the United States as one of the 10 comprehensive models by that National Research Council report that I mentioned before. And also in the National Autism Center's National Standards Project, it was named as one of the 14 established treatments for autism. It's a treatment that we're still actively researching here at Stanford, and I'll tell you a little bit about that research later on. But the core of PRT is the idea of targeting pivotal areas, that instead of breaking skills down into 1,000 pieces and teaching those 1,000 individual discrete skills one at a time, we focus on just a few core areas that are expected to have large, widespread benefits for the child's development. And one of the areas we'll talk about especially today is motivation. So PRT addresses the core deficits in social motivation that are so common in autistic folks.
Sometimes in a center-based session, we might bring a child into our classroom and just see what toys they gravitate towards, what they want to play with, rather than presenting them with something that they need to do. While we observe, we can start to think about and identify activities that are motivating and reinforcers that we can use and deliver to encourage children to communicate and interact. So we can have this kind of open format where we just follow a child, see what they're interested in, try to join them, or we can provide choices. Sometimes giving choices of things that you know they typically like to play with can be helpful if they're having a hard time choosing something themselves. Another thing we can do is we can try to entice them. So we can play with some things ourselves, see if they look at you, see if they come to you. These are all ways to analyze child choice. Once you have a pretty good idea of what the child is interested in or motivated for, we need to get some level of control over the situation so that we can deliver contingent reinforcement depending on the child's response. So there are all kinds of things we can think about in terms of shared control. But basically, we need to find a way to either briefly interrupt or maybe add additional stimuli to be able to have control over the situation. So when you're thinking about a lot of kids like tablets or phones, and that can be a good source of motivation and reinforcement, but we want to think about how we can be involved. So maybe if the child wants to play with the iPad, you're going to allow them to do that, but you're going to have some control over it. Maybe you're holding it with them. You're teaching them that you're able to pause the video, ask them a question, or prompt them to ask to play the music. When they respond, you're able to provide more of that reinforcer. Another idea is if you're playing with a ball with a child and you're rolling it back and forth, child rolls the ball to you, you get some very clear shared control. They still look interested and excited, and you deliver a prompt, roll the ball. The child says, roll the ball, and you can roll it back to them. This is really important because often children with autism are harder to motivate than typically developing children. They don't have the motivation to please others like other kids might have. And so it's important to really understand what's important to them and what's motivating to them and meet them where they are. This is something we talk about with clinicians and parents often because sometimes these repetitive or rigid routines can be boring for us. But the reason that children continue to engage in these routines is because they like them and they're motivated to do so. So we can get creative and try to think about how we can join them in those repetitive routines and think about how we can get some shared control to facilitate a lot of different communication opportunities. So we have a nice video that demonstrates shared control here. We'll watch it and then we can talk about what we're seeing. The three strategies related to reinforcement. So first, something we're all probably familiar with is the idea of contingent reinforcement. It's really, really important that the reward is delivered immediately after the child's behavior. This is how we all learn when we be able to access with other people. So if we're delivering direct and natural reinforcers in clinical settings, then when they're at school or when they're at the playground, they're able to access those same reinforcers when they engage in the behaviors that we teach them, and they're going to stay really motivated to try to communicate with others. So here are some clear examples. You can prompt a child to say up and you can pick them up, or you can prompt a child to say all done and you can remove the activity. Later, when kids have more language skills, we might teach them something like, asking a question during a conversation or making contextually appropriate comments about what someone said. So we could teach them to have a back and forth conversation about something that they really like And after they've done that, we can then do the thing that they like. Maybe it's playing a game, or maybe it's looking at pictures from a trip to the zoo that they took over the weekend. So really making sure that the reinforcers that we deliver are natural and related to the things that we're asking children to do. There's a nice video example of a therapist working with a child here that shows, at least related to the components, are videos of children in a clinical setting. It's really, really important to emphasize the role that parents play in the treatment of their children. This is a core principle of PRT. But parents can be arguably the most powerful interventionists for their children. Parents know their kids the best. Parents know what they're motivated for, what feels hard, what feels easy. So if we can empower parents by teaching them the clinical skills necessary to deliver effective treatment, we can really make a difference in the long term for children and families. All caregivers ideally should be involved in a child's treatment. So this can be parents, grandparents differently, pretending you forgot to pour the juice in the cup before you give the child their drink, can all be ways to create opportunities at home. And then in our, we saw some great examples earlier, but there are a lot of sensory social routines where we ourselves can be the reward. If a child likes to be tickled, we can deliver that reinforcer. If they want to be picked up, we can pick them up when they request. So all of these things are things to think about in terms of creating natural opportunities throughout the day. And as we think about natural environments, it's important to think about the fact that all of us have kind of different environments that we encounter and participate in on a daily basis. So ideally, these opportunities and strategies are incorporated throughout and across environments. So that could be at home, at school, and in the community. That's kind of the typical group of environments that children participate in. And there are benefits to each setting. So in a center-based setting, we have more of a controlled environment. We can control who's there and what is there. We might have opportunities to practice social skills and academic routines, and we might be able to observe children with peers, whereas at home we might not be able to do that. However, the home environment is really important in terms of family involvement. So we can really incorporate parents and grandparents and siblings. We can practice activities of daily living, and we can integrate things that the child encounters pretty regularly in terms of their own toys or their own, bedroom and their own environment that they're really familiar with. Sometimes we ask, is one setting better than the other? And that's one of the questions that we're looking at to answer potentially through some of our research that we're doing at Stanford. So I will hand it back to Dr. Grace, who will continue to talk about our research initiatives here.
Thank you. So I wanted to share a couple of slides related to some of our published studies on PRT. These are in partnership with my colleague, Dr. Antonio Hardin. A number of years ago, we completed our first randomized controlled trial of PRT, testing out a group method for training parents how to deliver PRT. And we did this with 53 children with autism who had significant language delay, 2 to 6 years old. And the parents were randomly assigned to either a PRT group versus a psychoeducation group where they learned about autism, but not about PRT. And we were able to show that in the parent psychoeducation group, in the sort of teal line, there wasn't a lot of change in fidelity of implementation of PRT over the 12-week period. That's not surprising. But we were able to get the vast majority of parents participating in the group did demonstrate over 80% fidelity of PRT implementation after the 12 weeks of group training. And not only were they implementing PRT, but their children were also improving in their use of functional utterances. During a 10-minute videotaped interaction with the parents, we saw by week 6, and then for sure by week 12, a nice significant difference in the amount of the frequency of functional utterances that the children made. And we published these data in 2015. And then we did a second study, another randomized controlled trial of PRT, where we combined parent training with in-home clinician-delivered intervention. And we had 48 children in this study. They were randomized to either a PRT package treatment, that combination of parent training and in-home treatment, or to a delayed treatment group where they just continued their stable community-based treatments. And what we saw in terms of their functional utterances in the same type of 10-minute structured laboratory observation is not a lot of change in the frequency of utterances in the delayed treatment group, but a nice improvement by week 12 with mostly maintenance in the week 24 period in terms of the frequency of their functional utterances. So children are certainly talking more when they have parents who've learned how to deliver PRT. In this study, 91% of the parents met the PRT fidelity of implementation criteria at week 24. And even more exciting, we used a measure called the Brief Observation of Social Communication Change, which is a measure that's designed to assess core features of autism, but is designed to be sensitive to change over time. And in this measure, a decrease in the score represents an improvement in the child's social and communication abilities. So we saw pretty stable functioning across 24 weeks for the children in the delayed treatment group, even though they were already receiving other community-based treatments, but a nice improvement in the PRT group in children's core social and communication skills. And this is part of the proof of the pivotal aspects of PRT, that even when we're targeting functional communication and working primarily on teaching kids to talk and to communicate with words, we actually are also seeing improvements in eye contact and gestures and joint attention and social initiations that are not explicitly taught in PRT, but are still very important. As we wrap up here, I'll share a couple of resources if you're interested in learning more about PRT. This first one is called Overcoming Autism. This is written by Claire Lezebnik, who's a parent of a child with autism, and Lynn Cagle, who's one of the developers of PRT. There's a PRT pocket guide that's like a nice manual for how to implement PRT. There's this Pivotal Response Treatment second edition book that's more of an academic text about the research behind PRT, and a recently published book called Naturalistic Developmental Behavioral Interventions by Ivana Bruinsma and her colleagues. And this is a great resource if you're interested in finding out more about the general category of treatments that incorporate both ABA and developmental perspectives. We also have an online course at Stanford for parents. For English-speaking parents who might be interested, please have them contact us at this email address, and we will be happy to enroll any parents who are interested in an online course about PRT. And we also at Stanford have a resource to help parents navigate service systems called the Early Support Program for Autism. So you're welcome to visit our website to learn more about that program. And finally, I'll acknowledge our mentors and collaborators. This is a partial list, but I want to especially acknowledge Antonio Hardin, Tom Frazier, Jennifer Phillips, Mendy Minjarez, who were part of the studies that I presented today. And we have a big team of research assistants, including Maria Stefania Milan and Robin Libov, who are part of the research that we presented today. And with that, I'll just thank you for attending, for your attention, and I'm going to stop sharing my